Thank you very much, and welcome everybody to this session. Before I start, I should probably tell you a little bit about myself. I am a Canadian human rights lawyer who had the benefit of actually doing my PhD in medical sciences, which makes me this rare interdisciplinary beast who has not yet figured out exactly how to bring the health and legal fields together. I recently left the Institute of Tropical Medicine in Antwerp, where I had worked for 7 years, and I'm now working in the law faculty at the University of Antwerp. And the first thing they said to me when I got there was, "Are you ready to do your PhD in law now so that you can be a professor here?" And I thought, I'm a New York State attorney. I did that bar exam, and now you want me to also do a PhD, and I did the medical stuff with all of the PubMed indexing and understood all of that, but there's really no complementarity crossover between those. So I will now try and give you a few ideas about how it's possible to use international human rights law when you're working in, and I'm focused on reproductive health because even though sexual and reproductive health need to be understood together, most of my work has focused more on reproductive health. So that's my limitation there. So the proposition that I have for you is reproductive health a human right or a commodity? It's a very topical conversation in many parts of the world. And ironically, as most of you know, in the poorest parts of the world, for the poorest people, no matter where they are in the world, often accessing healthcare is a problem because it is treated as a commodity, something that you are free to purchase if you value it, which to me is a false freedom. And in many countries, you are accorded access to it if you're a valued person. That's my problem with the commodification of health services. Whereas if you take a human rights approach, we talk about universal access, and we right away enter into the whole human rights panoply of principles of participation, accountability, transparency, human dignity, empowerment, and importantly also the rule of law. So human rights is essentially for law something that's very different. It's not a conservative discipline, it's a transformative discipline, trying to bring more people into accessing rights rather than holding the status quo. So I would argue that the consequences of this commodification of health are manifest in what I call the inequity of the global birth lottery. And to me, it's no more evident it is most evident when you look at this lifetime risk of death in childbirth and the differences between the Democratic Republic of Congo and its former colonial master Belgium, and then for Malawi and its former colonial power, the United Kingdom. What sort of transfer of scientific knowledge and human understanding was there between those countries? I don't think there are any more. Yeah, 2 right there and 1 there. So to me, this is one of the greatest inequities that exists on this planet. And I believe that human rights has a role to play in diminishing this inequity, in addressing the fact that people are not valued when they are female, when they are poor, and when they are invisible to the community. They are left to die. So, concretely, how does human rights law help address reproductive health injustice? And I'm talking about injustice. I don't know if human rights necessarily gets us to justice, but it's a pathway towards it. And it's one tool. I'm not saying human rights will solve all reproductive health problems, but it is one tool in moving us in that way. And I want to just review 4 things with you today. I have a short amount of time, but I can touch on each of them to give you an understanding. And I'm here for the whole day, so anybody who wants to talk about this with me in any greater detail, I'm very happy to, because it's a real passion of mine. So first, I want to remind you of the international human rights standards and treaties. Secondly, speak a little bit about case law, why I see that as a little bit problematic sometimes. Another form of accountability for shared responsibility, what I did my PhD research on. So this is moving even beyond just thinking of development assistance as charity, but as a right. And finally, the new global commitments, the SDGs and the new global strategy on children's, adolescent, and women's health. So again, why a human rights approach to reproductive health? Well, firstly, I said the universal nature, setting minimum standards for how individuals and institutions should treat people. Non-discrimination, equality, and participation are the guiding principles. And then accountability and empowerment. So empowering people with a framework for action to demand accountability when their rights are not realized. What are the key documents that we see reflecting this particular paradigm? And I got a long list here, and I like listing them simply because I'm old enough to have been around when I was told by people that rights really don't mean very much for health, and we're not really going very far. But if you see the last two that I have here, the Millennium Development Goals and the Sustainable Development Goals, they're not legally binding documents, but the influence of rights and rights thinking in those is very clear. And that means that the people who have been talking and fighting since the 1970s, during the 1980s, the 1990s, we do see progress. So when I start to feel depressed, I look at the list and say, actually, we are moving forwards, and that is an optimistic assessment that I need to remind myself of. So what does the human rights framework do within these documents? Well, it provides a legal framework, which is tied to the rule of law, which insists on accountability for the obligations that states commit themselves to, either in the non-legally binding documents like the SDGs or in the legally binding documents. And it tells us what governments cannot do to us, so respect our rights, do not sterilize us. It tells us what governments must stop others from doing to us, so protect us. Regulate, for example, the pharmaceutical sector or healthcare providers to ensure that there are quality services that are non-discriminatory. And finally, it tells us what governments must do for us over time. So economic and social rights have this concept of progressive realization and core obligations which governments are required to fulfill. They cannot delay this fulfillment indefinitely. And for those of you who like the legal basis, as all lawyers like to say, what is the legal basis for you saying this? Well, we start with a legally binding document, the International Covenant on Economic, Social, and Cultural Rights, and the incredibly vague Article 12 definition of the right to health, which has been expanded on, but you'd have to go to other lectures of mine to hear about the right to health. And I think it's important for us to look at this map here, that all of the dark blue are states parties to the covenant. That means that they have discussed, signed, and then taken the step of having their parliaments ratify their adherence to this treaty. So they have actually talked about it, discussed it, and accepted that they will be bound by these obligations, which provides a tool for lawyers, for activists, for academic, for medical personnel to hold their governments accountable and say, you made this commitment. They remain empty words on paper if we don't hold them accountable. Now you'll see a couple of pale blue, royal blue, however you want to think of it, countries like the United States, which stands out there to me, which signed but never ratified. And as we know, under President-elect Trump, we have pledges now to roll back efforts to move towards universal health care, which I'm sure most people in this room are just appalled at the thought that somebody would think to move backwards on these things. And we also have countries like Mozambique, which have not yet taken on these obligations. So, what does that tell us about universality? Not very much, if you're not even meeting the core obligations in most of the countries that have signed. So it's still very much a work in progress. It still very much remains words on paper until we start to move towards accountability. Governments that signed and ratified the covenant have been told what their core obligations are in the area of health. And non-discriminatory access is something that is a real top priority that they will be assessed on. And we've also had flowing out of this universality agenda and trying to bring the health and rights community further together, a Human Rights Council publication, guidance, which is actually something concrete that medical practitioners and policymakers can look at, on applying a human rights-based approach to the implementations of policies and programs to reduce preventable maternal morbidity and mortality. That, to me, is a really important document because it brings the medical practitioners together with the lawyers. So accountability, Brazil. Lauded for a lot of the progress that it has made on economic and social rights. And this case of Aline de Silva is a very disturbing case, a 28-year-old woman who, mother of one, left to bleed to death over a long period of time at several different health facilities, not being admitted for treatment. Her family was brave enough to take this all the way up to the Committee for the Elimination of Discrimination Against Women. It's the first case looking at maternal mortality that this international body made a pronouncement on, and condemned the practices and policies of the state of Brazil in terms of the discrimination that was experienced by Aline de Silva, because she was, in their words, a poor female Afro-Brazilian, so a member of a vulnerable, marginalized group, and was therefore denied access at the health facilities that she went to, be they public or private. They denied her access to the care that she needed to prevent her from bleeding to death over a long period of time. So they found that the government had failed to respect and protect her rights, and that they had failed to fulfill her rights by constructing a healthcare system that was non-discriminatory. And they noted that these failings were systemic, and they have asked Brazil to remedy these. And Brazil, to its credit, does take this seriously. Some countries do not, but Brazil is one that has. So my problem with such decisions is that what does this do for her family? I can't imagine losing a family member and then deciding to go to court year after year after year. So these decisions are important because they tell us that the international community does care and will say something, but it does nothing to stop what is happening on the ground. So to me, where we need to look more for accountability is looking at the policy decisions, the funding decisions that impact on the ability of health systems to deliver accessible, appropriate, quality reproductive health services. And as you well know, it's maternal morbidity, mortality is something that is most prevalent. 99% of preventable deaths occurring in developing countries. That means that we need to look at our obligations, our legal obligations, under this covenant for development assistance and cooperation. And so I've been forced to track funding for different types of health interventions, different types of development assistance. And as you can see from this chart, where did I put my pointer? This is the funding for HIV/AIDS, and then maternal, newborn, and child health. You'll also note that I have 2011 here. Development assistance for health has pretty much flatlined. It's remained at about 35 million US dollars, billion US dollars per year. So I was going to go through the updating process, but the updating doesn't change these numbers. So where does this money go when we know in 2011 we still had unacceptably high rates of preventable maternal mortality? And how do we hold the richer countries accountable and responsible for fulfilling their promises to pay this money rather than just commit it? Because we also get many commitments on paper, as you all well know. Well, there is a legal basis that is important because, as I said before, it's a legal obligation, but very hard to actually go and claim those before an international development agency. So the way in which the international community attempts to fulfill its shared responsibility is by setting up new institutions to which it pledges money. I would say that the Every Woman, Every Child commitments made 2010, 2011, highest level global political commitment of the UN in doing this. And the global strategy for women's and child's health, again, focused very much on accountability, so taking in a human rights concept, the rule of law and the importance of it, and also focusing on innovations in financing and efficient delivery of health services. Efficiency gains cannot be made when your health service is extremely underfunded. So we have to look at this more through a prism of understanding. For middle-income countries, the efficiencies. For high-income countries, we may well be looking at efficiencies. But for lower-income countries that are entirely dependent on donor funding to be able to deliver any form of health service, let alone efficient, effective, quality health services, some of these commitments and promises are hard to understand. So one of the things as a human rights lawyer that has made me happy was that accountability, as I said, has been at the forefront of these new international initiatives. We had initiatives before, but with very weak accountability mechanisms. The human rights mechanisms, as I said before, the map with all of the countries that had ratified and signed and ratified the treaties, again, the human rights mechanisms are also weak. So if we're looking at other institutions, the independent expert review group that was formed to hold the international community responsible for its commitments did a lot of very, very good work on pushing for countries to report on what was happening, pushing for the international community to report on this. And it made a lot of progress in moving this up the political agenda. And I would say that one of the consequences of their strong work in appealing both to the medical community, human rights community, donor community, is that we now have this global strategy for women's, children's, and adolescents' health that has, again, a strong accountability mechanism. Issued its first report this September. And if it can be as strong as the IERG, the one that was attached to the first version of the global strategy, I think that we will be in a better place for demanding that donors and countries live up to their commitments. And those commitments are also found in the non-binding Sustainable Development Goals. I'm sure you've probably already spoken about them here. Goal 3, important for our purposes, Goal 5, and Goal 10. But these are just, again, words on paper, commitments on paper, unless we get the money and the policies to fund them. I don't know how much you've been speaking about Goal 3 and its impact on international and national discourse and policies. I would say, again, that from an optimistic perspective, the fact that we have Target 3.7 in there is thanks to people like you being very vocal at international conferences and holding the feet of international leaders to the fire and making them make this a priority. Because the universal health coverage goal, So the universal health coverage goal in 3.8 is another indication of how the WHO was weak in being able to shift this goal up, this target up to the ultimate goal. But for this community, the fact that we have a target in there is immense progress. But then I would say what we need to focus on, not all of us, but many of us, is where is the money? There's a global financing facility set up by the World Bank. It is supposed to help to fund all of these breakthroughs in in health. And unfortunately, it is not receiving the funding that it needs to get. There's a real shift in the discourse towards requiring national governments to fund and bringing in the private sector to fund. And I would say shared responsibility is not just about bringing in the private sector. Bringing in other actors is a very good thing. But national governments and the international community have made human rights commitments to share the responsibility for fulfilling rights, and they need to be held accountable for that. I can't hold ExxonMobil accountable for funding this. There's just no way that I can. It's charity, and charity is not going to solve these problems. So I'm going to finish here with 3 messages that I hope you can take away. The first is that reproductive health is a universal human rights issue, and it's linked to fundamental human dignity. And that is something we should never lose sight of. When you violate people's rights, you take away their humanity, and that is something that is unacceptable. The second is that the human rights framework that I briefly touched upon allows us to hold leaders accountable when they do not meet their human rights obligations. And thirdly, that as somebody who has been working across and within different disciplines, and I know that you're a very multidisciplinary group here from all different areas, it can help us to enhance accountability. Because for me, the work of medical researchers provides evidence of violations that I can then use when I'm analyzing a policy, and I can work with my medical colleagues to understand, is this an effective thing to do? If I'm hoping to deal with access to emergency obstetric care, should I be looking at these ridiculous shock suits that have been developed, or should I be looking at strengthening the health system? And I know what they have told me is don't waste your money on these ridiculous ideas. The technological solution is not there. We need a strong health system. And I think we all need to use our voices to keep reproductive health on the political agenda. We have done a really good job of this, as I would argue, with the SDGs and this new global strategy with putting adolescents also into the global strategy. But we need to keep the pressure on, otherwise we lose the attention of the international community and, unfortunately, and our national governments. And that is not where we want to be. So thank you very much for your attention. We are now going to have 3 presentations, and then I think it said we would have a panel discussion. Thank you.
Thank you so